Good morning or good afternoon, ladies and gentlemen. Let me introduce my PhD topic, which is the role of knee injuries in the development of osteoarthritis. My name is Miklos Máté. I'm a fifth-year resident at orthopedic and traumatology department at Uzsoki Street Hospital. My vision is to bring along and also to develop our center, and my mission is to have decision-making for the daily practice and to have a more clear picture about posttraumatic osteoarthritis. I have three ongoing projects. In all of my three projects, I am investigated the connection between ACL injuries and post-traumatic osteoarthritis. First of all, I've made a meta-analysis in this topic. In the second one, we made a more accessible X-ray retrospective follow-up study, and in my third project, it's an ongoing project. We are prospectively follow up ACL injured patients as well. So this is my three projects. In my first project, the meta-analysis is about conservative and surgical treatment in ACL injuries. ACL injuries are one of the most common sport injuries, which mainly affects young and healthy populations. The numbers in the US are really high, and based on a recent meta-analysis, the prevalence of osteoarthritis is up to 50 to 90% after 10 years. Although superiority of surgical treatment compared to non-operative is low, and also the results, the progression of articular cartilage degeneration are controversial. Our aim was to analyze short-term osteoarthritic evolutions in these patients. Here you can see my PICO. As I mentioned, surgical treatment versus conservative treatment were the two comparable stuff, and the outcome was the development of osteoarthritis in short term. Our hypothesis was that there is no difference between surgical and conservative treatment on developing post-osteoarthritis or post-traumatic osteoarthritis. Here you can see our systematic search. Some words about the knee osteoarthritis outcome score, because this was the only outcome which we could use in our two RCTs. It is a patient-reported joint-specific score. It's really widely used in orthopedics. It assesses patients in 5 different scales. 0 indicates the worst case, and 100 indicates the best case scenario. In our plots with these 5 scales, only quality of life favors surgical treatment. The other 4 scales, pain, symptoms, function of daily living, and function in sports and recreation, had no significant difference between the two groups. We also made a table from our MRI findings, which were quite interesting. Also, what every colleague mentioned, the heterogeneity were huge. But in one of these studies, clearly seen that early cartilage defects were visible after 3 months compared to the 5 years after surgery picture. We also made a systematic review of the outcomes. The outcome scores had a huge variety. This is why we only could synthesize this Q score with 2 RCTs. So it also was hard to see, but we found interesting findings. I'm not going to say about our strength, but the limitations are these. The thing that only 2 RCTs can compare was not the best thing what we could find, and also the high variety of grading system limited us. In conclusion, in young active adults with an acute ACL tear, a strategy of ACL reconstruction doesn't provide better patient reported outcomes at 2 years. What we have found with this Q-score, but not only the Q-score, we also have seen it on our systematic review part. So to summarize, it could be advisable to have more randomized trials. The most important thing is that we need standardized protocols and grading systems to have a more clear picture about this. Secondly, this is my stated of the manuscript. It is in revision at the Injury Magazine. Hope it's gonna work to get it in. So the second project is a retrospective X-ray follow-up study. We have seen isolated ACL injured knees, and we compared it with a contralateral healthy one. These were our main criteria, but I'm going to go through the other criteria that the MRI follow-up study, and we have seen the osteoarthritic changes on X-ray, and the clinical implication is were to see the post-traumatic osteoarthritis on X-rays. It was an retrospective study. We used the special view. It was a posterior anterior view. It's called the Rosenberg view. It's a 45 degree flexed knee, and we used the Kagan-Lorentz grade for measure the results, and we also measure the joint space narrowing in millimeters. And our aim was to investigate the injured and contralateral healthy knee. The results. I'm not going to go through all the results what we have, but the interesting thing was that also in the less than 5-year group and in the after 10 years group, we found a significant lateral joint space narrowing on these X-rays. In conclusion, we could say that altered knee kinematics can cause early onset post-traumatic osteoarthritis, and also the first symptoms of osteoarthritis could appear in X-ray in less than 5 years after surgery. This is the manuscript status. We finished the article, and also we would like to send it to the Injury Magazine. The third one, based on these results and based on our findings, we would like to go through deeper with MRI in these results. So limited data exists with isolated ACL injuries, but cartilage deterioration have been written by the recent the studies. Subchondral edema demonstrated more than 80% on MRI, and the connection between initial bone bruise is still unknown. And also bone bruise could be a significant factor for degenerative changes based on a Japanese study. Our clinical question was, does ACL reconstruction decrease development of osteoarthritis? And we also would like to make a study on transtibial tonal positioning, which maybe can also affect the development of osteoarthritis. The PICO is almost the same like the other X-ray study, and also the hypothesis is we hypothesize that ACL reconstruction is chondroprotective. Here you can see the protocol of our study. I'm not going to go too deeply in it, but we have a structured protocol which our aim was to standardize those patients. We do the surgeries. We choose the mechanism of the injuries. So this is one of the biggest bias in the orthopedic articles, that the heterogeneity of the patients were what everybody choose. So the outcomes are we are going to see with a special MRI. It's a special sequence. It's called the T1 row mapping, which can see in the early part the chondrocytes proteoglycan depletion, and also the bone marrow lesion, what we would like to compare during the time we are making these MRIs. We also go through the ICRS questionnaire, which we found the more comprehensive for these early signs of osteoarthritis. And also we have secondary outcomes. The IKDC scoring system we are filling up with our patients, and also the longitudinal interrelationship with the altered tibial position is our aim to investigate. To have an overview, all of our 3 studies are focusing on ACL reconstruction, and based on our meta-analysis, we just built up these protocols to have a more clear picture, what I have mentioned also. And lastly, I'm really thankful for this program that me and my colleague went to one of the biggest orthopedic conference in Boston this year. So I'm really thankful it. Thank you for your attention.
Since I represent here the Translational Medicine Center, so I have questions about submission. So in your first submission, is this the very first submission, or you submitted somewhere and then you got the rejection?
No, I have. This is my first submission. Actually, it's a Hungarian supplement for the Injury magazine, and we just asked that maybe they are interested in this one. But I'm saying I've just written that it's a Q2 journal, but in Luca's slides I could see that it's a Q1, isn't it? So sorry about that.
Okay, that sounds better, because then what we actually ask the fellows, I mean, to do the first submission to a Q1 journal. So
yeah, actually we just made the discussion with Peter also that Q1, Q2, and I just didn't change it. So
yeah, fine. But also with your second submission, I mean, well, I understand that's retrospective. So I mean, to publish that, it is still not that easy. Your first study, you should go for a D1 journal. You see, if you really achieve that, I mean, kind of randomized clinical trial stuff, you should go high. This is not only for translational medicine, but you all should go high, and that's an important purpose of the whole program, actually, to support fellows in all areas, and then actually to go in high-level journals, so that makes your career better or higher, that your department higher, the university higher, and so on, and science is actually better visible.
With all the respect, Professor Varga, we were discussing with also Szilárd and Peter. The main problem is that we have only 2 RCTs, and
yeah, I understand.
We tried to went through a big systematic review to open up this topic, but the lack of the comparable data and comparable outcomes was our biggest bias, actually, because and this is why we are not trying to go for the biggest D1 journals, because we discussed it.
I'm talking about your last study, and that's just a subject.
The last. Okay. So you mean the retrospective?
Yeah.
Yes.
Okay.
Thank you.
My statement probably don't like you. Looking at these 2 talks, De Jonge and yours, it's just the same project. I don't know, just the same for me. And looking at the journal, the Osteoarthritis and Cartilage, Bence sent this title, Non-Operative Treatment in an Excellent Option for Isolated ACL Injuries. Yours, no difference in outcomes after ACL injuries comparing surgical and conservative treatment. So I'm sure the message is just the same. So definitely don't send to OA and cartilage your article.
Yes, we are working in the same group. Our supervisor is the same. When we started this program, we have a previous search and previous study in ACL reconstructions, and yes, this was the first thing what we started. And after, when we go deeper and deeper, we just go to the same point that the results are controversial. We don't know. The only thing we know that ACL reconstruction now is not contraprotective. When the initial injury happened, your cartilage deterioration is going to go through. The question is that is it going to go through with micro instability, or is it or it's going to go through with a stable knee? But also, we don't know what is better for a patient. There are a lot of, in orthopedics, there's only a few parts where you have gold standards. A lot of operating techniques, and actually, this is why we try to do these studies. That maybe if we do the surgeries, if we choose the correct patients, if we choose the same injury mechanism. For instance, with the X-ray one, we choose only indirect valgus mechanism injured patients. Maybe we could see more objective data from that. The objectivity of these data were.
I have one general question. It seems like everybody here loves the journal injury. For various reasons, obviously. Did you ever try to go to some American journals before, or is that too complex, or are you afraid of the rejection rate?
No, I wasn't afraid. It's just because it finished about 2 months ago, and there was this opportunity, and we tried it. This was the reason why we didn't go through. But actually, Robbie's quite similar study went for the AJSM, Dr. Dainger's study. So and it has a positive answer in it. So now it's on the OJSM, right? So it's also an American journal. So, and actually at ISACOS, what we have seen there, the same what we are struggling in. They are saying that Q-score, yes, it's a good one, but we use others. Some say from Greece that we use another one, which is our specific score. So it's
I agree. But also you keep in mind that there might be also some more specific European journals which are a little bit more related to sports as injury, I would say, in general. But it's just a suggestion. It's not a criticism, because the impact factor that you can achieve with injuries is good, I would say. And I remember when I started my career in scientific work, I also used injury sometimes.
But actually, it's also our start.
Right. That's
the start of our career. We don't know what to expect actually. But thank you for the comment, because maybe
they should try other journals as well. Just a recommendation.
My question would be that you mentioned in your first study that the only significant difference was in the quality of life of the patients, if I'm remembering correctly. And I wanted to ask you that do you know why is this the case? So if in the objective measurements there was no difference, what might be the reason that the quality of life is still better for the patients who had surgical treatment?
Well, actually, it's thank you for the question. With this case, quality of life it's also a self-reported questionnaire. So there is no such thing that it was like the rate for 0 to 100. You can measure that how painful if you are standing up from your bed. So these are just everyday questions, and I don't know why it favors the surgical. Maybe maybe because those little micro instability is not there with the operated ones, and maybe in the everyday life it somehow have a better result there, but not that significant if you can see the data.
The topic you choose is really hot, and I would be interested in that. Did you try to compare the different surgical solutions regarding ACL reconstruction, regarding the late osteoarthritis or the complexity of the ACL injury, like the plasmaticide lesions or something else?
Well, actually, our main goal was that we are. I'm going to show you our protocol. That we have excluded the patients who has concomitant injuries. So all those. So we only focused on isolated ACL injuries. Or the question was that. Would we consider with these or sorry, I didn't really understood what was what.
As the question would could be worthy to include those patients for a different subgroup analysis. Yeah. And the first question was that did you make any difference between the different surgical solutions like the BTB or hamstrings?
Yes, we have read a lot of articles, and one of the main problems was that there were isolated, and there were patients with medial menisci injury and other concomitant injuries, and we want to exclude it. Yes, and the comparison of the BTB and the hamstring. This is your question, and we mainly do hamstring. We have chosen patients who we put hamstring grafts, and not yet planned these two types, because also there's a lot of studies and also RCTs which were compared these two graft types, and we just want to have something new and something unknown. Yeah.
I have only one question. What is the practice in Uzsoki Hospital in acute lesion?
We mainly use transtibial positioning. I mean, the surgical technique, because we mainly use
conservative or operate.
Well, it depends on the surgeon actually. Mm-hmm. So we have seen that especially in my clinic, I also try to have these try to put this knowledge into our care, that not all the patients needs surgical treatment, especially if somebody has, the MRI says that ACL lesion could seen, but when I see clinically there's a positive anterior drawer test, but a negative Lachman test. In that case, it means that it's probably a proximal rupture. Yes, it has one cross laxity, but it means that it's only a proximal part lesion. And sometimes also in my clinic, I could see that the patients are happy with this little bit laxatable ligament, and there is no micro instability on that. So
excellent, thank you. This is the translational medicine.
I'd like to ask one regarding your second topic, the X-ray follow-up study. There was this mentioning of this slide that you are using the Rosenberg view X-rays. Why this and not the conventional AP X-rays?
Yes, thank you for the question. We read a lot of articles, and we found that Rosenberg view has a better insight in the intercondylar notch, which is important in early onset osteoarthritis. So this is why we use Rosenberg view for that.
And what do you think? Why is it narrowed, the lateral joint space? in this study?
Yes, what we discussed that actually we have chosen patients who got there is two injury mechanism, direct stress and indirect stress, and we have chosen patients who injured with indirect valgus stress, which when the initial injury happened, it's mainly effects on the lateral joint space, and especially it's really interesting to see it with an MRI, maybe in the early phases, that because of that indirect valgus mechanism and the lateral joint space, can we see chondrocyte or proteoglycan depletion on this area, because the X-ray stands for it. So I think it's a really interesting topic to see with our prospective follow-up study these results.
Okay, in case of this study, what kind of statistics were done?
Well, we use the standard deviation and also the p-value, which is lower than 0.5. There were two. In this case, the results were in millimeters, and we compared it. So,
But what kind of hypothesis test was used here?
The main difference here, and
T-test. The student T-test.
The T-test, yes, this was the statistic. Yeah.
Okay, and in case of the first project, where you have two studies, the outcomes are from the same study as I see.
No, it's from two studies.
Two studies, but the different outcomes were in the same study. They come from the same two study.
Yeah, the same two studies.
Okay.
Yes, exactly.
Good.
Exactly.
Luckily, you don't say that it is a significant or not significant different, but clinically, what do you mean? It was clinically relevant or not?
Yeah, it could be it could relevant, because you can see that people think that somebody if not has surgery after ACL injury may have way more worse quality of life and function in sport, but we could see that with the patients reported outcomes, it's not the fact. So it's almost the same.